Change your heart.
Okay,
Nice.
awesome. Welcome. Okay, so welcome. We're just talking about the genital urinary system, and tell me everything or anything that you know about it. So, say started us off saying that the kidneys were filters, right?
Yep.
Okay, Bria, what do you have to tell us about the genital urinary system? Anything about it?
I just think of KUB, so kidneys, ureter, bladder, waste products, just how I say it again, the waste out. Um, I think of disease processes,
Okay.
complication and tests we can do, catheterizations, things like that, kidney failures.
Okay, she's so fancy. I love it. Okay, excellent. Okay, I'm gonna skip Jessie because I see that she's busy right now, but we'll come back to her. Okay. So, Bria gave us a lot of things to kind of talk about, right? And so when we think about the kidney, I want you to think about it regulates your acid-base balance. Think about fluid electrolyte balance. So it also excretes metabolic waste. So think of your creatinine, your urea. And so it also helps to regulate the blood pressure. When we think about the kidneys, the urinary system, yes, we're thinking of the kidneys, the ureter, the urinary bladder, and the urethra. So think about that it helps to also regulate blood pressure via renin. Also, I want you to think about the kidneys making erythropoietin, which helps to stimulate the production of red blood cells. So there's a lot of things that goes along with this, genital urinary system when we talk about it. Okay, and so things that can contribute to someone's kidneys not being well, well, it could be a history of genitourinary disorder. It could be a history of hypertension because hypertension affects the kidneys as well. Could be a history of diabetes that affects your patient that has kidney issues. A family history, again, a strong genetic component. And there are also conditions like polycystic kidney disease. And when we talk about issues with the urinary system, okay, when we talk about issues with the urinary system, excuse me, we're thinking incontinence, we're thinking BPH is benign prostatic hypertrophy, even cancer or kidney stones, or even medications that affect the kidneys, right? So some nephrotoxic kind of medications things that the manifestations that we think of if a patient has actual kidney issues, right? Like a UTI, which we're going to discuss a little bit later in our case study. Well, we know that flank pain, right? That flank pain is something that is a classic sign. We think of that pain radiating to the upper thigh when we think of maybe your patient that has a UTI or even maybe kidney stones. Also, that pain can radiate to the testes in your male patients or the labia in your female patients. So, things that we think about when we think about genitourinary system is changes in voiding. Is there any blood in the urine, right? Hematuria, protein in the urine, proteinuria. Okay, dysuria. What's dysuria?
No urine output.
Difficult.
Difficulty or painful. So, anuria would be without urine. And what's that magic number that we're looking
30
for?
miles an
30
hour.
mils an hour.
30
30 per hour.
mLs per hour. That's right. That is classic for your adults. Okay, very good. So again, hematuria, that's blood, and we can have macroscopic blood and microscopic blood, blood that you can see with the naked eye, blood that we may need a microscope to see. Protein in your urine. When I say protein in your urine, what kind of patient do you think of automatically? What comes to mind?
Diabetic.
A
Kidney
diabetic
stones.
patient. I think of a patient that has gestational hypertension, right? That has preeclampsia, maybe severe preeclampsia, right? So
Mm.
that's what comes to mind because we're not supposed to have protein in our urine, right? That's an abnormal finding. Okay, what about frequency? What kind of patient comes to mind when we think about frequency of urine?
BPH.
Yes, I gotta go right now. And I keep going, right? But there's dribbling, there's hesitancy that goes along with it. Okay. When I think polyuria, what kind of patient are you thinking?
Diabetic.
Okay, yes, absolutely diabetic. Okay, maybe
Oh,
also.
what's that word?
Diuretics,
It's the word date that you mix up the word diabetic and diabetes and the other word.
insipidus.
That one, yeah.
Okay,
Diabetes insipidus.
diabetes insipidus. That's true. Okay, that is true. Okay, excuse me, which diabetes insipidus is separate from diabetes. It's not even has anything to to do with the other, right? And so when I
Right.
think of polyuria, I do think of that diabetic patient. And Bria also said something that's important too when we talk about the medications affecting the GU system is your diuretics. That patient is diuresing, releasing the extra fluid, right? Okay, and so what are some of the nursing considerations with this patient taking the diuretics?
In the morning.
Okay, so take the diuretic in the morning so they will not be up all night because they're a fall risk. They won't be able to sleep. Okay, excellent. What else?
Fluid restriction after like 6 or 7 p.m.
Okay, yes, absolutely. Fluid restriction. And this patient is probably going to be on I's and O's as well, right? All of those
Mhm.
things go with it. Okay, excellent. So I have some things listed up here as far as things just to, I'm going to briefly mention. If there's anything that you're like, man, I don't really remember that, and I can go into more detail, but I'm just going to briefly touch on it because I want us to leave some time for the questions and breaking down those questions. Okay, so when we think about urinalysis, what's some of the things that comes to your mind?
That's like an analysis of urine just based off a patient, maybe if we're concerned about a UTI.
Okay, sure. That's an excellent place to begin. I like it. Okay, what else?
Also to measure like kidney function and then also drug screen.
Okay, absolutely. Right. And so urinalysis, as nurses, we get excited about our patients' bodily fluids. And so 30 mLs per hour, we know that that's the normal standard, right? Unless it's a kidney patient that's not really necessarily going to have any urine output. But when we look at urinalysis, we're looking at the consistency, the color, the amount. Is there any sediment? Is it odoriferous, right? Is there any blood? So all of those things are going to be important. We think of specific gravity. Okay, that's one of the values that we have to have memorized. And when we think of specific gravity, and I'm going to put the normal levels in the chat, but this is also something that you probably have memorized at this point. And so my book, I'm using my ATI book that has all of the lab values. Some books will say 1.010 to 1.030, but this gives a little bit of a lower end, 1.005. But I always remember it 1010 to 1030 when we think about specific gravity. Protein is a normal value is going to be 0 to 8. And again, we really excuse me, really have a red flag if we have a patient that has protein in their urine. Okay, glucose, we don't want a lot of glucose in urine either. Excuse me, because that's going to be a sign of a patient not having their blood sugars under control. Ketones, we don't want any ketones in the urine either. Okay, what happens if we have ketones in urine? What does that suggest for your patient?
Not DKA, is it? Um,
Yeah, excuse me, diabetic ketoacidosis.
oh,
Yeah, so
awesome.
DKA, right? So we definitely don't want ketones in the urine. That's not another abnormal finding. The normal pH of urine is going to be from 4.6 to 8. So slightly acidic and a little bit basic. Right. And thank goodness we're not tasting urine back in the day that you used to taste urine to see if it was like a little sweet because they didn't have the test back then. But that's a random fact. Okay. That's way, way back in the day. What if we have white blood cells that are high in urine?
Infection.
Okay, yes, signs of infection, right? So all of these things like, okay, yeah, I know that you know that, but I'm bringing it to the front of your mind because we're doing a good review. We've got a lot of folks joining us. Look at all these graduates in the house. It's so good to see all of these graduates. We're talking about the genitourinary system, and just talking about the kidneys, the ureter, the urinary bladder, the urethra, and we're just talking about urine at this point, some of the values that you have to commit to memory. And we're going to jump right now into these diagnostic tests. As we jump into the diagnostic test, does anybody here have any questions or comments or anything they want to share about the GU system?
My son actually got a test to do tomorrow because he's going through the whole potty training thing, almost finishing up by the way. But if I let his urine sit in the pot for like a couple of hours, I noticed like orange flecks, which is from what I remember, uric acid to some level. So yeah, I called his pediatrician and like, she wants him in like ASAP to get tested. Like it's not blood, it's orange. So it's like little orange flecks. It just you don't see
Okay.
it when he first goes, but if it sits and settles, yeah, it separates and yeah, I think it's uric acid for some reason. A lot
Okay.
of protein.
So let me ask you this. When you kiss him, is his skin salty?
Just go lick it out like he a puppy. Oh well, I mean, I can do it now if you want.
I mean,
Chill, come here. Hurry up.
no, no, I'm not. I'm just saying because that's
He
one
got
of
a
the
chicken nugget in
things.
his hand, so his hand might be salty. Is it supposed to be? Like, how salty are we talking?
Um, it
Like,
really
I mean,
sh
he runs around, so he's a toddler, so he might be a little. Where am I supposed to be looking at his lip?
Lick your hand. Lick
okay,
yourself. I was licking myself. I ain't salty. So lick yourself.
okay.
Me?
So that's one of the things. If you remember from Pete's, when you kiss the
Yes.
baby is salty.
Yep.
Okay, so that's why I'm asking. So yeah, you don't have to lick your son or anything, and it sounds like you're taking the appropriate steps, but I was just curious since you said that
Oh,
maybe the doctor said that there was a buildup of uric acid. So let us
I'm
know.
curious about finding out how they gonna test him because he just not gonna pee on cue. So I'm thinking they're gonna straight calf him, and I don't think I want to be in the room when that happens.
I think you might have to be there, Mom. So, because you're going to be the one to keep him calm. Okay, so that's actually a really interesting thing. And I'm not really sure because I don't have a lot of experience with peds. So, that's going to be interesting. So, let us know how it works out and, what other tests they have to run because that's going to be quite interesting. Okay. But that's really good that you made that observation because you could have, caught something really early. Okay.
Yeah,
Awesome. Is there any strong ammonia smell or anything with the urine, or is it just the orange flecks that specks that you
just
see?
the, just the orange specks.
Okay.
After urine just sits for a while, like it's almost like like how blood like separates after you do things, it just kind of separates. That's what his urine does.
Okay. Interesting. Okay. I'm gonna have to write that down because I don't really know a lot about that. Okay. Awesome. Thank you for sharing. So again, we get excited about bodily fluids, right? So we think the color, it should be amber or clear. We should have negative glucose, negative protein, negative for nitrates, negative for red blood cells, negative for white blood cells. When we have a void for a patient, the preferred void is first thing in the morning, right? That's going to be the preferred void. And think about also when you have to instruct your patient for a clean catch. And I never really see this done, but that's something that you can have as a drag and drop kind of thing. Remember that you have to give the patient three of those antiseptic wipes. And for the female, we're going to wipe on the left, we'll wipe on the right, and then wipe down the center, right? With each with a new wipe. Then if it's a clean catch, they will start to urinate, they will stop, right? And then they will urinate into that cup. that sterile cup, and they don't want to contaminate that cup. Now, if it's a male patient, excuse me, you're still going to give 3 wipes. They're going to start at the glans penis and then work your way down the shaft, right, with the 3 separate wipes. So the same thing goes. They'll start to urinate, stop midstream, and then urinate into the sterile container. So that's going to be important to teach your patient on how to get that clean catch. Okay, so when we think about a renal function test, what's going to be a good indicator of kidney health? We're thinking BUN. If the patient has a BUN, and what's the normal BUN, by the way? I'm going to put it into
9 to 11.
okay,
I mean,
9.
10 to 20. I'm sorry, I'm thinking about something else. It's 10 to 20.
Okay, that's better. I was like, oh, I don't know about that. Okay.
I
Okay,
was thinking about
so
something else.
okay, BUN is 10 to 20. So an increased BUN, what does that possibly indicate for your patient?
Some type of renal injury.
Absolutely. Absolutely,
Whether it's
right?
acute or chronic.
Yes, so absolutely something's going on, some kind of renal issue, renal disease. I remember, and I probably shared with this group before because I think I was with you for med surge or something like that. When my mom told me, I think her BUN was 62, and I'm like, what? Right? So again, the normal is 10 to 20. So I was really flabbergasted. And the rest of her numbers were totally off the chart. But as you know, my mom is a kidney patient, right? She's a stage 5 kidney patient. She has dialysis 3 times a week, but she's doing great now. So she's really paying attention. So increased BUN may indicate hepatic or renal disease. It can also indicate dehydration or decreased kidney perfusion. It can also indicate a high protein diet. So that's maybe your patient that's working out, keeps going to the gym and they just keep having all these protein shakes, bro. And they're just like working out, getting pumped, getting really buff, right? That could be a problem for your patient. And that also makes me just want to remind you that that kidney patient should not be having high protein because their kidneys can't handle it, right? So when we think about nutrition and dietary restrictions. Now, the high BUN may also indicate infection. It could indicate stress. It could indicate steroid use. It could also indicate a GI bleed. Okay, so all of those things, think about it critically when you have your scenarios and they present, these lab values to you. Now, creatinine is going to be the best measure of renal function. So we all know about that 24-hour creatinine clearance test, right? Tell us about that. Can anybody tell us about that 24-hour creatinine clearance test?
Is that where you void at the start of the test and then you start your clock and you keep everything, and at the end of the 24-hour period you void again?
Okay, so you are voiding. So I think you're on the right track, Jessica. So
Well,
go ahead, say you're going to give some more information on that.
uh, it's showing how fast, like, I guess the kidneys can clear the creatinine out your system. It's comparing the numbers, like just said, before and after.
Yes, and so this is a 24 excuse me, this is a 24-hour clearance. So we're actually collecting urine, but the first void of the morning is discarded. We're not going to use that one. And we are going to collect all subsequent voids. So it can't be contaminated with tissue. It can't be contaminated with stool or anything else, or we have to start all over again. Okay. And so it's usually kept in those big brown, they're kind of brownish containers in a refrigerator, or it's kept on ice. That's going to be the important thing. Now, after the completion, right, of remember the first urine of the morning is discarded, then all subsequent urines is going to be collected in that big brownish container. So that's going to be important, and then it's going to be stopped, and then that will be sent to the lab to be analyzed. And you're right, Sam, when you say we're looking at the amount of creatinine that's inside of the patient's urine. So absolutely, but that's going to be key. Make sure you discard that first void and it's not contaminated with toilet paper, stool, or anything else. Okay, that's going to be important. Okay, PSA is another test that's important when we think about the GU system. PSA is that prostate specific antigen, and if it's greater than 10, it indicates a great risk of prostate cancer. Okay, prostate cancer. Okay, so radiological tests, well, Bria already mentioned, she said the KUB, the kidneys, the ureter, the bladder, the urinary bladder. So that's going to be one test. Obviously, if it's a female patient, we have to make sure if she's of childbearing age that she's not pregnant before we have the patient take this x-ray. Excuse me. Okay, also they can do an IV pylography. And so this is the contrast dye. Okay, and so of course, when any contrast is given, what do we have to do? Assess for allergies to shellfish, to iodine. And so whenever there's any dye that's given, we always assess for allergies, and we have to have a good patent IV. That's going to be important. We're going to educate the patient that as this dye goes through your system, you may feel a warm sensation. Honestly, it feels like fire going through your veins, but you don't tell the patient that. But it is a warm feeling. It's going to be a warm sensation. And that's that anticipatory guidance, okay? Now, if your patient has to have, any procedures done on the GU system, things that we have to keep in mind that I know that you all know, but I'm just going to mention to refresh your mind, right? We have to have that verified consent, that informed consent that has to be scanned into their record. We have to verify the patient's last creatinine level. The patient should be NPO for 8 hours. Excuse me, depending on the testing that they're going to have done, maybe they can have fluids. It depends. Okay, maybe sometimes they can take medication with sips of water, that kind of thing. If the patient needs to have laxatives, we have to make sure that that laxative preparation has been taken care of and has followed. Maybe the patient needs to have an enema completed, right? And remember, when we're performing an enema, we're in the left lateral position, that left lateral sims, because of the way the intestines go, right? From ascending transfers to descending. So the patient's going to be lying on their left side. Remember, when we're administering an enema, we're stimulating the vagus nerve. So keep talking to your patient, because if you're stimulating that vagus nerve, their heart rate could drop. They can become bradycardic. They can, lose consciousness. So although all of those great things, another thing with the enema, if the patient is cramping, then you want to lower your enema bag, right? All of those great things to think about. Okay, we talked about the allergies. When the patient is getting the contrast, besides the warmth, tell them that they may have a metallic taste in their mouth. That's another bit of anticipatory guidance. Okay. Also, make sure that you have emergency equipment for every procedure, right? So that could be your breathing bag, your artificial airway, just depending on what's going on with the patient. All emergency equipment should be standing close by. Now, if your patient is having a procedure that uses dye, of course, after the procedure, we want to encourage the patient to push fluids to get the dye out of their system, right? All of that's going to be super important. All right, I'm going to jump into a renal angiography. So what happens with the renal angiography? We are visualizing the renal arterial supply, and contrast material is injected through a catheter. So this is, just like any procedure, just like if it's a catheterization of the heart, right? We think about it again, we're looking at the dye scenario. So we're assessing the allergies. We always, when we have an invasive procedure, we think about patient positioning, we think about hemorrhage, we think about infection. And so nursing interventions pre this procedure, we want to make sure that we prepare the area for the approach. Usually the approach is through the femoral or the brachial artery. Okay, so usually it's through the femoral or the brachial artery. And so we always want to locate and mark the peripheral pulses, because whenever a patient is having any catheterization done, we always check the most distal pulses, right, to make sure that there's adequate blood supply, adequate perfusion. That is a good practice for any nurse to do. Okay, before this renal angiography, we want to make sure that the patient is able to void beforehand. And again, let them know about the warm sensation of the contrast dye. Now, post-procedure, this patient is going to be on bed rest 6 to 8 hours after this renal angiography. Excuse me. And we're going to monitor their vital signs. As with any procedure, we always want to monitor their vital signs, looking out for signs of hemorrhage and infection. Hemorrhage will kill the patient fastest, right? We're going to look for swelling. We're going to look for hematoma. A small hematoma, a small blood bruise is okay because we just stuck a needle through, right? But we have to monitor that. Okay, again, the peripheral pulses, we're going to be checking the patient's eyes and nose and also looking at their urinary status. Okay, so that's with the renal angiography. Any questions so far about any of the things on the list? Okay, let's go to cystoscopy now. So this cystoscopy is an invasive procedure in which a scope, right? Whenever there's a scopy, there's a camera that's going to look at something, right? Is passed to view the interior of the bladder, the urethra, or a portion, excuse me, or the position of the urethral orifice, or to remove calculi from the urethra, the bladder, or the ureters. This cystoscopy could also be used to treat any lesions of the bladder, of the urethra, or the prostate. Okay, so this is, of course, an invasive procedure. So pre-procedure, we have to make sure the patient is NPO. We have to make sure that we give the appropriate um, preoperative cathartics, enemas. Again, same kind of thing, making sure that if they need bowel prep, just because of the proximity, they want everything to pretty much be empty, right? As also in case they nick something accidentally, it's better that there's not bowels full, of stool that's going to be released into your abdomen now. Okay, so that's also another reason for them eliminating this. Hold on. Something is happening to my cat. Hopefully he's okay. All right. Okay, so the other thing that the nurse has to make sure is we have to monitor for postural hypotension. So postural hypotension, the patient's blood pressure drops from lying to sitting to standing. So we have to watch out for that. We also have to teach the patient how to do deep breathing exercises in case they have bladder spasms. Bladder spasms are really painful. And of course, we can give medication for that, but until the medication kicks in, or if it's breakthrough kind of spasms, we've got to teach the patient how to breathe. That's really, really important. Okay. We also have to teach the patient before this cystoscopy that they could have pink or tea-colored urine right after the procedure. But if they have bright red urine and if they have clots, that should be reported. That is a big, big thing for nurses. If any patient has bright red urine, large clots, report that immediately for the LPN and the RN. Okay. We also want to provide pain management for the patient and educate them on how they're going to manage their pain. Now, post cystoscopy, we're going to assess for leg cramps because the patient is going to be in the lithotomy position. You all are ladies on this call, so I know you're familiar with the lithotomy position. Imagine being in that position for hours and hours and hours, right? So we're going to possibly have leg cramps, maybe even possible DVTs. So we have to really make sure we monitor for that very carefully. Assess for back pain, assess for abdominal pain. A sitz bath may be appropriate for this patient, a warm sitz bath. We want to push fluids and provide analgesics. And of course, this patient is going to be on eyes and O's. Okay, let's jump to renal biopsy. What can you all tell me about renal biopsy?
That's when they taking a piece of it. Okay. That's when they taking a piece of I'm trying to figure out what part they taking. I just know they're taking a piece of it.
Yes, and so you're right. It could be, and so with any biopsy, they're taking a large bore needle and they're taking fluid, they're taking cells, they're taking tissue. It could be maybe a tumor, maybe they're, checking out a growth, whatever it is, but they're going in with that large bore needle. And whenever there's a biopsy, we have to think, of course, about infection and hemorrhage. Hemorrhage is going to kill the patient the fastest. We think about pathology. Whatever they're removing is going to be sent to pathology to be tested to see if it's cancerous or what is the consistency of the fluid or the cells or the tissues that they removed. So, excuse me, those are all things to think of with biopsies in general, right? Now, for the renal biopsy, again, this was really with any biopsy. We want to make sure that we check the patient's bleeding, clotting, or what are their prothrombin times? Are they taking any blood thinners? Because if they are, they're going to have to stop those medications at least a week, maybe even 2 weeks prior to the procedure, because that increases the risk of bleeding. Okay, so we want to make sure that the informed consent is there. Excuse me, we want to make sure that we get the results of the x-ray because we want to make sure that, okay, is it the right kidney or the left kidney? All of those things are going to be important. We want to maintain IV fluids where that patient's going to be NPO for 6 to 8 hours prior to the procedure. We're going to position the patient with a pillow under their abdomen and their shoulders on the bed because think about their flanks have to be available because that's the area that the surgeon is going to be working on. Okay. And we want to inform the patient to be very still during this procedure because this is not done under general anesthesia. It's going to be local anesthesia. Excuse me. Post procedure, we want to maintain the client in the supine position and they should be maintaining in bed for 24 hours. Okay, so we want to monitor the client's vital signs every 5 to 15 minutes for 4 hours. Again, we're concerned about hemorrhage. We're going to maintain pressure on the puncture site for 20 minutes. Observe the client for any pain, nausea, vomiting, blood pressure changes. Encourage fluid intake. Assess their hematocrit and hemoglobin 8 hours after the procedure. Why do you think that's important? Excuse me.
Bleeding.
That's right. Bingo. Bingo. All right. Okay. Make sure the client avoids strenuous activity, sports, or heavy lifting for at least 2 weeks. Okay, awesome. So that's your renal biopsy. Indwelling urinary catheterization. Fun times, right? Indwelling. So this is a sterile procedure, and we are trying to empty the contents of the bladder, obtain a sterile specimen, determine residual urine, irrigate the bladder, or bypass and obstruction. Excuse me. All right, so with this is a closed system, and we're going to measure the patient's output every shift. Pericare, meticulous pericare is going to be important. Keep that drainage bag below the level of the client's bladder, below the level of the waist, but not on the floor, please. Increase the patient's daily fluid intake if it's prescribed. Prevent any kinks or dependent loops, right? And don't milk the catheter tubing, okay? And we want to discontinue the use of this indwelling Foley catheter as soon as possible based on the patient's condition, okay? Okay. Excuse me. All right. So, if you don't remember the steps of inserting a Foley catheter, that's something that you should review real quick because that could be like a drag and drop, put in order kind of thing. But I think you all should be able to figure that out. And just remember too, that we're no longer inflating the balloon. Evidence base says when we inflate it, we actually could possibly make it weaker. So we're not testing it prior to inserting it into the patient. Okay. And I'm sure that's something that you probably also seen in clinicals or skills lab. Okay. So specific disorders. So in general terms, with our urinary disorders, we want to, if it's tolerated by the patient, push fluid, encourage cotton underwear, wipe from front to back. We don't want that E. coli from the anus coming up to the urinary meatus, right? All of those things go for patient teaching and whenever we're doing anything with the urinary system. So that's going to be for every single condition, pretty much every patient, right? And so I'm just mentioning in general terms because it's going to apply. So when we think of cystitis, that's an inflammation of the urinary bladder. Contributing factors, not wiping properly, prolonged baths, BPH, indwelling urinary catheters. So how is the patient going to present? They're going to have malaise, they're going to have burning, dysuria, they may have hematuria, cloudy, foul-smelling urine, fever, chills. Okay, urinalysis may show that they have increased protein, white blood cells in their urine. They may have leukoesterase. They may have casts, bacteria in their urine. So this is going to be one that we would actually do the clean catch that we talked about, and we would expect antibiotic therapy. We would want to maintain acidic urine pH. We want to push fluids, and when we push fluids, we're talking about 3,000 mLs per day, okay? Encourage the client to drink cranberry juice. Now, sometimes cranberry juice might be sweet. They have like, the cranberry chews, or they can mix it, half cranberry juice, half water, that kind of thing. If your patient is a diabetic, that might be a concern because that cranberry juice is kind of sweet. There's a high sugar content. Okay, medications that we're thinking of, right, is your sulfonamides. And of course, always assess for allergies to sulfa, um, nitrofurantoin. And I just was doing questions. I don't remember with which group it was, but that was one of the medications, and it might have been with this group, that it turns your urine a dark color, and that's a normal finding, right? Okay, yeah, it was with this group. Okay, so that's something to keep in mind. Okay, urinary analgesics. And so that's your phenazopyridine. This may turn the urine orange. So, and I'll try to send it to you all. There's like, I've seen a table with medications that turn urine like different colors. That's something definitely to look at because there's some medications turn your urine brown, blue, orange. And that's something to definitely know to make sure you're educating your patients. Okay. Again, bubble baths are not good. Long baths are not very good for these patients with GU issues. Okay. And they have to avoid before and after sexual intercourse. That's going to be important. Okay. So this is cystitis. We're going to jump to acute glomerulonephritis. So acute, remember this is a sudden onset. So this is an acute renal disease involving the renal glomeruli. Remember the glomeruli, that is that's surrounded, and that's the functional unit of the kidney. Inside is the nephron, and the nephron is the functional, one that does the work inside of the kidneys, right? Excuse me. So if a patient has acute glomerulonephritis, it's involving the renal glomeruli of both kidneys. So it's an antigen antibody reaction that damages the glomeruli of the kidney. And so I like this visual because it gives you, okay, wow, what can happen? These complications that can happen with acute glomerulonephritis. Now, this could be acute glomerulonephritis, could be a secondary response. A lot of times it could be due to a beta hemolytic streptococcal infection. I've seen questions where it was like, okay, little Johnny's sister had strep throat. Now little Johnny has acute glomerulonephritis because apparently that strep infection was missed in him, and it was undiagnosed. So 2 to 6 weeks after that initial infection is when these complications can occur. Okay, so tonsillitis, pharyngitis, and again, strep throat and this patient can end up with acute glomerulonephritis. Okay. So what are the manifestations? Well, hematuria, excuse me, cola or tea-colored urine with protein in the urine, edema, especially of the face and around the eyes, periorbital edema, ascites, that round protuberant abdomen, okay, oliguria or anuria. So oliguria is less than 30 mLs per hour, and then anuria is without urine. Hypertension with headache, flank or abdominal pain, or even anemia. So with this patient with acute glomerulonephritis, we want to maintain bed rest to protect their kidneys, restrict fluids, increase their calories, and reduce protein. Well, that makes sense, right? Because we just said in the beginning that kidneys, we don't want that kidney patient to have a lot of protein. Is going to make the kidneys work harder. And monitor their daily weights. Medications for this is going to be your penicillins, corticosteroids, and antihypertensives. Antihypertensive medications. Okay. All right. Any questions so far? Okay, we're going to go to nephrosis now. Okay, nephrosis is a clinical disorder associated with protein wasting secondary to diffuse glomerular damage. Okay, so it could be autoimmune, and so manifestations. So it's kind of a slow, kind of insidious kind of onset. The patient will have pitting edema, and then they'll have generalized edema, and the nursing word for that is anasarca. That just sounds bad. Oh, you have anasarca, right? But that is generalized edema, anasarca. Okay, so other manifestations of nephrosis is protein in the urine, anemia, hypoalbuminemia, so low albumin, okay? Low levels of albumin. And that makes sense because I know that albumin is a protein that keeps the blood in the blood vessels. But if we have an issue with protein wasting, that means protein is going to be coming out in the urine. They're losing protein, so they're going to have low levels of protein, which is your albumin, which kind of makes sense, right? Anorexia, malaise, nausea, oliguria, and ascites again goes with this. So this patient that has nephrosis, we want them to be on bed rest during the period of severe edema only, and that is your anasarca. Remember, that's generalized overall edema. Monitor their eyes and nose, prevent this patient from infection. That's going to be important. Weigh the patient, and we're going to measure their abdominal girth to see is their ascites getting worse, right? Medication therapy for nephrosis is going to be your loop diuretics, your furosemide, and it's really worth going over these medications again. I don't know if we're going to have time to talk about the medications, but it's worth looking at these medications again and looking at the side effects and the nursing interventions, like your furosemide, take in the morning, don't take at night, make sure you toilet the patient every 2 hours, a clear lit pathway at night, those kinds of things, because they're a fall risk because they're going to be diuresing. We have to monitor potassium levels. So all of those kind of things go with it. Now, besides loop diuretics, furosemide for nephrosis, they can have steroids because of this autoimmune inflammation. So prednisone may be the medication of choice. And they may also give immunosuppressant medications, again, because this is an immune kind of condition. Okay. All right. We are going to talk about now urolithiasis. Whenever you think lithiasis, think stones. All right. Kidney stones can happen anywhere inside of the urinary tract. So inside of the kidneys, in the ureters, in the bladder, in the urethra, often painful when passed. Okay. And so it's an obstruction. And so your patients that have urinary stasis, the urine that's just sitting there, they're at increased risk. If a patient is immobilized, they're at increased risk. If a patient has high levels of uric acid, they're at increased risk. Okay. So for your patient that has urolithiasis, these kidney stones, push fluids, strain their urine, provide pain control. Medication of choice is going to be opioids because it's really very painful. like your morphine. Okay, the NSAID ketorolac is going to be used in the acute phase. Allopurinol is going to be for uric acid kidney stones. That makes me think of gout, right? Allopurinol is the maintenance medication for gout. So your gout patient is at increased risk for kidney stones, right? Okay, so teach your patients to avoid foods that are high in oxalates if they have oxalate stones. And there's like 5 or 6 different kinds of kidney stones. Excuse me. So that's why they usually catch them. They strain the urine to test them to see what kind of stone it is. Okay, spinach, black tea, rhubarb, and chocolate also should be foods avoided if your patient has these kidney stones. And of course, adequate hydration is going to be key. Okay. Now there is lithotripsy that goes with stones. If the stones, are not able to pass, they may need to put them on this water. It's kind of like a water bed, and they shake them up, right? So they can do the lithotripsy to break up the stones. If that does not work, then sometimes they may even have to have surgery to remove the stones. Okay. All right, but that's of course a last resort. All right, let's talk about your renal failure. What's the difference between acute and chronic renal failure?
Acute is sudden and chronic is they've been having it for a while.
Okay, yes, so chronic is a lifelong kind of thing. So when we talk about acute renal failure, an abrupt decrease in renal function, it may be a result of trauma, allergic reaction, drug overdose, kidney stones, or shock. Okay, so think about pre-renal, renal, and post-renal issues. Pre-renal is there's not enough blood flow. So pre-renal is before the blood gets to the kidneys, something is happening. Renal, there's some kind of trauma, something going on with the kidneys. Post-renal, something is compromised after the kidney. So it could be maybe a kidney stone is clogging a ureter, right? But pre-renal, renal, and post-renal. So the manifestations of acute renal failure, you have the onset when they have the event. I had a patient one time that had acute renal failure because his boat capsized in the Chesapeake Bay. So he was treading water for hours and he was hypothermic, right? So this onset begins with the onset of the event and it lasts for hours to days. The oliguric phase is 1 to 3 weeks. Okay, sudden onset, less than 400 ml in 24 hours. The patient is going to have edema, elevated BUN, creatinine, potassium.
We can't hear you, Miss Anasia.
Oh, I'm sorry. My daughter hugged me and she muted my mic. Okay. Okay, so oliguric, 1 to 3 weeks, sudden onset. Can you hear me now? Okay. All right, good. Less than 400 mLs in 24 hours, edema, elevated BUN, excuse me, creatinine and potassium, increased specific gravity, acidosis, heart failure, dysrhythmias. Okay, the diuretic phase, right, which is going to be the third phase because it's onset, oliguric phase, and then the diuretic phase. Diuretic phase is what it sounds like. Urine output increases. And so they can actually diurese up to 4,000 to 5,000 mLs of urine per day. Okay, so this is indicating that they have recovery of the damaged nephrons. Excuse me. Now, this patient in this diuretic phase, they're going to have a decreased urine specific gravity. Makes sense if they got 4,000 to 5,000 mLs of urine a day. Hypotension and fluid and electrolyte imbalances are a concern, which I know you all are good nurses, and you know, just like this with diabetes insipidus, if a patient is losing copious amounts of urine, they're going to be losing copious amounts of their electrolytes, right? So that is going to be a thing to look out for and to monitor very carefully, and we'll have to replace those missing electrolytes, right? Now, the fourth phase, remember onset, oliguric, diuretic, and then the fourth phase is the recovery phase. This could take actually up to a year. Okay, so for that patient's kidneys to get back to normal. Okay, and older adults, of course, they're at greater risk for residual impairment, unfortunately. Okay, any questions about those four phases? Because that could be tricky in acute renal failure. Okay, good. All right. Let's talk about your chronic kidney patient, and I'm going to bring up the dialysis, right? That's my mom right there. Just kidding. So when we think about your chronic kidney disease, so this is a progressive failure of the kidney, remains that can result in death unless the patient has hemodialysis or they have a kidney transplant. George Lopez is a kidney recipient, right? Just in case, just random fact. All right, so stages of chronic kidney disease, excuse me, stage 1 through 5. 5 is the worst, most serious. They cannot survive unless they have dialysis, and that is ESRD, end stage renal disease. Okay, and it's all based off of the patient's glomerular filtration rate. Okay, so stages 1 through 5. And so, what are some of the factors that can cause a patient becoming a dialysis patient on end stage kidney disease? Diabetes, uncontrolled hypertension, chronic glomerulonephritis, pyelonephritis, congenital kidney disease such as PKD, polycystic kidney disease. Ethnicity, African Americans are at greater risk, Native Americans and Asians. Okay, so what are the manifestations? How does the patient present? Okay, fatigue secondary to anemia, headache and hypertension, nausea, vomiting, diarrhea, irritability, edema, excuse me, hypocalcemia, hyperkalemia, pruritus, that uremic frost, right? Okay, pallid gray yellow complexion, metabolic acidosis, elevated BUN, creatinine, decreased glomerular filtration rate. Okay, so nursing interventions for your patient that is with chronic kidney disease: maintain bed rest, especially if during a time for crisis. We're going to monitor, treat their hypertension, strict eyes and nose, fluid replacement. The ice chips count. Don't let the kidney patients fool you. The ice chips count, okay? They have to maintain dialysis 3 times a week, provide meticulous skincare. Well, that makes sense because I just said it, they have that uremic frost, right? Emotional support, assess for bleeding tendencies. Epoetin alpha is going to be given because guess what? Their kidneys they're not making erythropoietin, right? So they have to maintain their dialysis schedule. Okay, so at this time, I'm going to stop because I want us to get into our questions. Anybody have any comments or anything based on, I know this is like a fire hose of knowledge of renal, but anybody have any questions or comments or anything? Okay, oh man, I had this open too long, so let me restart it. Okay, I'm gonna do the bow tie question for prostate cancer. And the bow tie question, it's kind of cute. It's like a bow tie. Let me pull it up here. Cat related. Okay, let me just get this ready. Okay, so we'll do the prostate cancer bow tie. Okay. I'm going to close these extra tabs so it doesn't slow me down, hopefully. Okay. All right. So just in case you're not familiar with the bow tie, I'll just do a quick rundown. It's literally kind of like a bow tie. So with every question that you get, you want to read the nurse's note, read the vital signs, look at all the information that's given to you, and you're going to have to give one thing in the middle, right? The condition, and then on the two ends, I guess the bow of the bow tie, you're going to uh, address two things: the actions the nurse should take, and then two actions the nurse should monitor based on this scenario. All right, so let's have Sarah kind of read through this for us, please.
Okay. A 55-year-old client is admitted to a surgical unit after a robotic-assisted laparoscopy radical prostatectomy for early-stage prostate cancer. At 1:15, the client was transferred from the post-operative care unit to the surgical unit and unit after robotic-assisted laparoscopy, oh my gosh, prostatectomy for early-stage prostate cancer. Client is alert and oriented ×4. Vital signs are normal. Has 6 small incisions in the abdomen with 4x4 dressings with clear dressing dry and intact. The client has an indwelling urinary catheter with continuous bladder irrigation draining clear red color urine. At 1:30, the client's dressing are dry and intact. The Foley catheter draining red urine irrigation rate increased. At 1:45, the dressings are dry and intact. Administered, I can't read it. Keto.
Oh, ketorolac.
Thank
Okay,
you.
if I make it bigger, will that help?
That does help my old self. Thank you. 30 milligrams IV pushed, and urine color is slightly red. At 2:15, the pain is decreased, but the client is slightly confused. The client's urine color is now bright red. Vital signs at 1:15 were 99.4 was their temperature, 85 was their pulse, respirations were 16, blood pressure was 145/73, pulse ox was 96, they're on room air, and their pain was 3 out of 10. At 1:30, their temperature was the same at 99.4, that pulse rate was 88, that respiration was 16, the BP was 130/73, that pulse ox was 96, they were on room air, and their pain was 3 out of 10. At 1:45, the temperature was at 99.2. That pulse rate was 102. Respirations were 20. BP was 110/70. Pulse ox was 94. They were on room air, and the pain was 6 out of 10. And at 2:15, temperature was 99.2. Pulse rate was 124. Respirations was 24. Blood pressure was 95/53. That pulse ox was 90. They were on room air, and their pain was 2 out of 10. Hematocrit was 32%. Hemoglobin was 10.
Okay, awesome. Thank you for reading that, Sarah. I'm gonna ask the group here of these graduate nurses, what's going on?
Pulse high, respirations went up, blood pressure went down,
Mm-hmm.
and blood levels went down. So they could be going into septic infection, sepsis. There we go.
Okay, so let me ask others what they think. Because so you hit some good points today, but let me see what others think.
So I guess what my
Is it
concern is, you
shock?
can see that the
Shock,
urine
yeah.
is changing colors, and it's turning from a clear to a bright red. So it has to be seem like to me some type of bleeding is happening, that he's pushing out due to the laparoscopic radical prostatectomy. And then his vital signs are reflecting that something's going on with his pulse rate increasing, his O2 sat is dropping, and his blood pressure is dropping.
Okay.
It's either septic shock or the blood shock. That one. Yeah,
Yes.
blood shock.
Okay, so say you're right to say shock. And so I think I see because you see that temperature of 99.2.
Mm-hmm.
Now, this patient just came out of the surgery. So usually the shock, the septic shock will come a little bit later, right? But definitely you're right to say shock. based on the patient is now becoming tachycardic, based on the blood pressure is now hypotensive, based on bright red. And remember, whenever you see bright red blood, that is a big red flag for you. I got to figure out, okay, this isn't right. Like, if you see a scenario and you're like, man, I don't know what's going on, but if you see bright red blood, okay, I got to figure out why this patient has bright red blood. Like, that's never a good sign for your patient, okay? So, especially if the urine is bright red and they just did a procedure, right, with the robot. So, this is what NCLEX is going to test you on, right? Can you pick up from these clinical cues, what's going on with your patient? Because that's exactly what this bow tie is asking you. So we did a good kind of analysis. You saw that the hematocrit, the hemoglobin was low, and earlier Sarah told us, or it was Jessica that told us, okay, because they're going to be bleeding, that's going to tell you, okay, the patient is hemorrhaging. That's why those values are low, right? So this is like a classic kind of hemorrhaging scenario, possibly, right? So let's see what is here. Excuse me. From the list of choices, drag one condition that the client is most likely experiencing to the box on the right.
Hemorrhagic shock.
Okay, so Sarah's holding up 3. Say said hemorrhagic shock. Anybody else say anything else? Okay, so we got hemorrhagic shock. Okay, so that's the middle of our bow tie. So let's do the 2 corners now. Drag 2 actions the nurse should take to address that condition in the box on the right. Okay.
IV fluids.
So Say says IV fluids. What does anybody else say?
Oxygen.
Oxygen. Okay. Okay, very good. Drag 2 parameters the nurse should monitor to assess the client's progress to the box on the right. What are 2 parameters to monitor?
Blood pressure.
Blood pressure.
Mm-hmm.
I'm feeling like the urine color since
I
it
would
was
say breath sounds. Well, wait a
I
minute.
agree with Bria. I think the
IV
urine.
The urine, right? Because the urine was what told us the patient was hemorrhaging, right? That bright red blood. And
Oh, yeah.
that's correct. So I know we always say ABCs, 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 right? But in this scenario, this is not necessarily an ABC kind of scenario. This is a patient hemorrhaging because of the procedure that was performed on their genitourinary system, right? And you got to give them oxygen because you saw that their oxygenation was going down from 96 all the way down to 90 on room air. Like, okay, they need some oxygen. Okay. Excuse me. And with any patient that's hemorrhaging, we want to give them a bolus of fluid, get them ready for that transfusion. Okay. But that's the correct answer. So the middle of the bow tie is hemorrhagic shock. The 2 bows on the tie, if you will, is administer IV fluid and oxygen, and I got to monitor their blood pressure because that's going to tell me if they're hemorrhaging, and monitor their urine. That's going to tell me if they're bleeding less, right? Because I should not see that bright red blood coming out in their urine anymore as their condition improves. Okay, that's it. Any questions on this one? All right, let's jump to it. If you all have time, we're going to do the case study on UTI.
Okay.
Okay. All right, let's go to, let's see. Tanya, you want to read this one for us, please?
Okay. The nurses caring for a 74-year-old female to a rehab unit following a right hip replacement 2 days ago. Nurses note, day 1, 0800, client admitted last evening from the hospital with indwelling urinary catheter in place secondary to urinary retention. Upon entering the room, thank you.
You're
Client
welcome.
found attempting to get out of the bed unassisted, stating, I need to feed the cats. Client also grabbing at lower back yelling, it hurts. Lungs clear to oscillation, vowel sounds, hyperactive, 4 quadrants, indwelling catheter draining, cloudy, yellow urine. Her temperature, the temp is 100.1. Pulse is 96, respiration is 16, blood pressure is 122/68.
Okay, excellent. All right, thank you for reading that. And she's a cat lady, right? She's a cat lady. My daughter is a cat lady. My goodness. All right, so drag the 4 findings that need immediate follow-up. Okay, so I'm gonna try to put it all on one screen. All right,
Confusion,
Urine, definitely.
okay.
temperature, urine.
So I heard someone say confusion. What did you say, Bria?
Urine.
Urine. Okay.
Mm, Bowel sound.
Oh,
What was the blood pressure? Oh, yeah. I'm
sorry.
thinking
Pulse
back.
rate
I'm thinking
Pulse
bowel
rate.
sounds.
is a little high.
So
Well, the
heart
pulse is
rate.
normal though.
You feel like
Well,
that's normal?
it's a little bit high, but it's still
74-year-old laying in bed? That's a little high to me, but
yeah.
yeah, because the blood pressure is normal. Bowel sounds were active.
Okay.
She's a little
Now,
Oh,
confused, so I mean, I would ask about pain, the pain in the back, but I kind of know where it's coming from.
okay. So you're saying
Yeah, I'm
pain.
kind of thinking the pain would be an issue, right?
yeah. Instead of
I
the
don't
heart
think the
rate, I would put
temperature
pain instead of heart rate.
or yeah.
So remove heart rate. Oh, I can't remove it one side. Okay, I was gonna say. Um, so confusion, temperature, pain, and urine is what y'all are going with?
Yeah.
Yeah.
Okay.
Okay. Sarah's like, I don't know.
Because
Okay.
pulse is 80 to 100. So, well, 60 or 80 to 100, but it's still technically in normal range.
Just whether we're resting, I don't like it. If I was on the floor and I was got patients that age, I'd be concerned. That's just personal.
Okay. Right. Now, this is a question. It's not saying that you're not going to follow up on the other things, but this is immediate follow up. So, out of all of these things, choose the 4 most important ones. So, that's a good strategy for this because you're like, man, I don't like that. I don't like this. This is not normal. Something's going on, right? She's saying she's in pain, right? But the 4 most important things. Number one is going to be confusion, and that is right because with your geriatric patient, confusion, sign of infection, they're going to hurt themselves. It's a safety issue. So there's so many things with confusion. So definitely confusion. The pain, absolutely. That's going to be something that we have to follow up on. Okay, the temperature, which is 100, again, that's linked to the infection. And then the urine, okay, that, excuse me, that cloudy urine is something is going on. And this is pointing to all kinds of infection, right? Urinary tract infection. Okay, so the vital signs, I know that you don't like the heart rate, but that's not going to be in the top 4, if that makes sense. But you're right to be concerned about that. You're absolutely correct. Okay. But it's still also within normal limits. Okay. And let me see. And I'm going to put the rationale in the chat as well. So you can have that to take a look at. Any questions about this one?
And Sarah, it may be a little bit more elevated too because of the fact she's trying to get out the bed and feed the cat. So she probably, moving around too. So
Yeah, when I feed my cat, my heart rate goes up as well.
yeah,
Yes. Well, if
yelling and
someone's stopping you from feeding your cat, you're going to be upset, right? So, yes. Okay. All right. So here's the second one. All right. So whenever you have these questions, this is kind of set up a little bit differently, but you're going to have the tabs, and I probably told you all this already. Check all tabs. Make sure that you look for any new information because that could, affect how you answer the question, right? Any new nurses' notes, lab values, x-rays, doctor's orders, blah, blah, blah. All right. So which problem could she be experiencing? This is a select all that apply.
Delirium,
Constipation, delirium.
and urinary tract infection.
UTI for sure.
Okay, so I heard delirium, urinary tract. What else?
Constipation, because it says hypoactive bowel sounds in all four quadrants.
Okay, so you say constipation.
Your bowel sounds hypoactive in all four quadrants.
I don't know why I thought that's the normal.
So based on that, you think she has constipation?
If it's hypoactive, it's not doing
I think
anything,
for the
right?
elderly, I thought that was kind of normal for like your
All right, let's take constipation out.
Okay. All right, good.
Uh,
I feel like you can't say renal calculi just yet because of course the pain
yeah.
is there, but it's I don't know. I think it's just those two.
I mean, they elderly. I mean, it could be dementia too. Talking about some feeding a cat that ain't there. Like, hey, but that's
You don't
also
want to
delirium too. So
what is it called? Elder
sundowning.
no, when we're calling them things because they're just elderly. We can't say just because she's 74 she had dementia.
True.
That's
Right.
Oh
right.
yeah, I forgot that word. It got something to do with it kind of means
Is
the
it
same thing as racism. I get it.
elder
Yeah,
bias? Elder
Bias, yeah.
that
Elder
one.
elder
bias.
Yeah.
bias. Okay. Yeah, so you can't say that. And also don't hate on her because she's a cat lady, right? So,
And then they
but
didn't talk about the
Lady
incision at
Michelle.
all, so I don't think it's incision infection.
yes. And so Bria,
Right.
you
And
were
that's it.
right. Yeah, so delirium and urinary tract infection, that's it, right?
Yep,
That's the
that's the
only
only
thing.
two I would.
Yes. So constipation, they try to trick you because they said the bowel sounds are hypoactive. Okay, but
But
they
she
didn't
just got out of surgery.
exactly. And they didn't say that the abdomen was hardened, right?
Right.
So
Yeah.
so you need to give me a little bit more before I say the patient is constipated, okay? So dementia, don't label her just because she's, talking about the
Seven.
cat, right? Incisional infection, did they tell us anything about the incision having purulent drainage, being warm or anything like that? Malodifferous? No. And renal calculi,
I was
there's
like, where did
nothing.
that come from?
Yeah,
Yeah.
there's nothing to support that, right? So this also tells us that we really have to look at the cues and what does each piece of information tell us? Because you're like, man, this is definitely a GU thing, so I'm going to just choose everything with GU, but it's not necessarily applicable. So don't let them fool you. Take your time and be deliberate with what you're choosing. Okay? All right, here's question 3. Drag the most appropriate word from the choices, excuse me, to complete the sentences on the right. What's the top priority to address for this patient?
The UTI.
Urinary tract infection.
Yes, okay. Easy peasy. I know that y'all knew that, right? Because that's causing all the other issues with the patient. Okay. And we said she didn't necessarily have all of these other things that are listed. Okay, awesome. Okay, so here's the nurse's note, still the same. Select the orders from each of the categories the nurse anticipates including in the plan of care. Each category may have more than one order. So there's nursing category and medication category. So I'm going to check what you all tell me to check.
Obtain the urine
Obtain
culture.
urinary culture.
Culture. I&O, maybe? I&O would seem.
You say I&O?
I'm not sure, but hold on.
So if you were the nurse,
Well, discontinue the catheter, but when you need an order to discontinue that?
okay. So if
Hold
you
on. The urinary catheter, didn't they say that was for retention? Or did
Right.
they say that was just
Yeah,
for
that's why I was like monitor, like, in the bag, see if it's still cloudy or whatever,
yes, I wouldn't discontinue it unless there's a doctor
Yeah.
order for that.
Yeah, so
Nope,
yeah,
no voiding
I would
trials or
choose
anything like that.
monitor I&O.
okay, so select I&O and urine culture.
And go ahead and apply that vest restraint because it looks cool. Don't tease me.
You gotta fail. You better not think that.
You're gonna lose your
You
license
going
before you
down.
get it. They gonna be like,
My
where you
license
get your
go.
license from?
I want to feed them cats too. Don't you think that?
Okay, so I'm just waiting for y'all to tell me what to
Yes, the
check.
clindamycin for the medications. You don't need Colace because she's not constipated.
Yep.
The Nezapil's for dementia and sertraline's depression. She's not depressed, so I think
That's it. Clindamycin. That's the only antibiotic up there.
yeah, it's the only one I see.
I mean,
Okay.
would that fix it? She is delirious though, remember?
She only that because she might have
Yeah,
urinary
you
tract
gotta fix the
infection. So I wouldn't, yeah.
yeah, you gotta fix the
Okay.
infection and
Yeah.
the
True.
Nezapil is not gonna
All
fix
right,
it.
just the antibiotic. Yeah, y'all right.
Yes.
Okay, so I kind of agree with you all. Now, this answer key is saying that we should discontinue the indwelling catheter because she has she has urinary retention. The thing that I don't like about that, though, secondary to urinary retention. If we do discontinue this catheter because it's probably infected, so we want to remove it, that part makes sense. We're gonna have to closely monitor her I's and O's. But I kind of now agree with discontinuing the catheter because it is infected. And that's
If
so
it's infected, yeah.
If we discontinue it on our own, do we just put a new one up there, or you have to get an order for that?
So you're
It's
still
an
going to have
order.
to get an order for it. And so because you're going to need, an order for the INO and you're going to need an order for the urine culture anyway. But for nursing, like what would you do as the nurse
So you would
in
need an
this
order to
case?
discontinue that. You just discontinue it and tell the doctor afterwards and make them mad.
No, you need an order to do that. This is also in the NCLEX world, you need an order. I mean, to do
Oh,
something like that, you still need an order. Even if you know that, hey, this is infected, this catheter is infected, is causing infection in my patient, you still need a doctor's order. And that's going to be really easy. It's just a phone call. The doctor will say, yes, discontinue it. And then you'll give a proper repeat back, a verbal repeat back. But I couldn't even imagine a doctor saying, no, keep it in. Like that just doesn't make sense because we know that she has a UTI and the catheter is probably infected at this point. So we do need to remove it. Okay. Now, the thing that really you have to watch carefully is if she is not voiding. That's going to
Urinary
be
retention, yeah.
that's going to be the key. And I might be giving you the answers to the next question, but in
Oh,
your nursing mind, that's what you want to be wary of. Okay. But discontinuing the catheter is a good call because it's infected. Because what happens if we don't discontinue the catheter and we give antibiotics? Guess
it's
what?
not gonna help.
She's
infection's
still
still gonna
gonna
be there.
exactly. So we have to discontinue the catheter. Okay. And I put it in the chat also. So that's good. Okay. So this has some new information. Anybody want to highlight it? Say, do you want to highlight the new information for us, please?
Oh. All right. So at 8:10 in the morning, healthcare provider notified. At 8:30, urine specimen taken from port of indwelling catheter using aseptic technique and sent to the lab for culture. Indwelling catheter removed. First dose of clindamycin administered on day 2 at 8 a.m. The client's awake and oriented times 3. Denies back pain, but continues to report mild incisional pain, 2 out of 10. Voided 520 mils of cloudy yellow urine. Temp 99.4. Pulse 80, respiration 14, blood pressure 118/70. Orders are urine culture and sensitivity now. Discontinue the indwelling catheter. Monitor INO and give clindamycin 250 milligrams by mouth every 12 hours for 3 days. Give the first dose now.
Okay. Excuse me. Thank you. The client's cognition has improved the next day after starting antibiotics. What should the nurse teach the client about the treatment plan? Select all that apply. I'm staying by to select the ones you tell me.
The first one.
One. Yeah.
Okay.
Urinary output will be closely monitored for the first 8 hours after catheter removal.
The second to last one about the culture and sensitivity.
Yeah, I just got there too. I guess it
Last one
increased fluid
too.
intake too.
Yeah.
Say that again. I'm sorry.
The last one.
The last one. Okay.
That's all I got for y'all. Oh, I ain't got nothing.
Okay. Well, there's some more.
I'm
Yeah,
looking at the
removing of the
third one.
catheter will help
Yeah.
restore body's normal flush out of bacteria.
Oh,
I mean,
yeah. I ain't even read that one. I'm looking at it like, what?
Okay, so note to self, read every single one because you know that these extended select all that apply can have up to like 10 different things, right?
Yeah.
So
now
take
that
your
further
time. Say that again.
okay, that further evaluation to rule out dementia will be needed. I got to go back up because they said she's 3 out of 4, but they didn't tell us what that one thing client is. Okay, 3 out of 4. So
Okay, I see what you're saying. She's oriented times 3.
right.
I ain't even gonna speak on it because I ain't trying to be elderly racist.
I
Elder
did see that
bias.
sometimes they
Oh,
chart like alert and oriented times 3 or times 4. So I never. Some people do the 3 and some people do 4. I don't know.
Yeah, so some 3 is normal.
Yeah.
Some people do
Oh,
that.
okay.
Excuse me.
I don't see any more to add.
Okay, let me see. So the entire course of clindamycin should be taken. So yes, that is true. And that's with any antibiotic, right? That's the normal standard thing. We're not going to say that she has that dementia. We don't, based on that, she was just confused talking about a cat, right? That's so we don't need to check that one. Removing the catheter will help restore the normal's body flora. Yes, that's true. Okay, urinary output will be closely monitored for the first 8 hours. Yes, and that's with any patient that we remove a Foley catheter, right? They are due to void, and it's going to be even sooner for your postpartum patient because we know that that full bladder, distended bladder, can cause the uterus to shift and increase the risk for postpartum hemorrhage. But that is the post void or due to void, actually. They're due to void when we remove the Foley catheter. Okay. And then the last two, and that's it.
yay.
That's it. Anybody have any questions about this?
I
Nope.
almost got caught up on the minimizing activity because I always think about when they tell the patient to rest. So I almost got tripped up on that part.
Yes. Now, yeah, so yeah, definitely not for this scenario. Not appropriate. Okay, very good. I'm glad that you didn't get caught up. Okay, let's see. I think all this other information is the same and orders are the same, I think. So this is a great one because it's like, okay, check whether the statement understands or does not understand.
The
Okay.
first one is no
She definitely don't
understanding.
understand the first one.
Yep. I cannot stop. No, that's not right.
Understand the second one.
Yeah.
Understand the third one.
No.
Not understanding
I
the
don't know if that's right though. I will buy cotton underwear from now on.
I mean, cotton underwear, if it's a female, you're supposed to wear cotton underwear, or you're
I
gonna have all
don't.
sorts of
That's not.
stuff going on.
She
You
said
don't
I
want all
will
that nasty
buy.
stuff coming out of
Okay.
either one of those holes.
I don't know. She probably needs some Depends. I don't even think she needs.
But is that the source of the? I mean, is that?
You get UTIs from wearing dark underwear
Oh
because
my God! But
bacteria
they're dark. But
bacteria
cotton.
loves dark, moist areas, and
Okay.
areas already dark and moist. And if you don't buy no cotton underwear, it's gonna be super moist like cake batter. All right. So yeah.
Okay.
Okay, I would take showers instead of bath. Let's say she understands.
Yes.
Okay. Baby powder. She don't understand baby
No.
powder.
Okay,
Oh,
see,
shut
that's
up. Look at you.
And no to that last
Embarrassing.
Sunburning when I void is normal.
okay, right. And so I know y'all had a lot of debate on the cotton underwear, but cotton underwear is the standard for
Yeah.
good female genital health, urinary tract health. White cotton underwear is the best because it doesn't contain any dyes or anything like that. That's going to be the absolute best.
Team
Okay.
Granny Panty all day.
No, I agree with you, but you know how sometimes you don't want to bring your own. I never learned it in nursing school, so now since I'm learning, okay, I never heard of it, so I ain't want to
Your
bring
gynecologist should
in
be telling you that.
who.
Your
Nobody talked about it.
Yeah.
gynecologist never told you not to wear no thongs
No,
and
I know, but in
crack and
school,
silk underwear and you know
in
that
Well,
sex thing.
school,
You can't wear those things all day, maybe for like 10 minutes, but you can't be wearing that stuff all day.
but yeah,
that's like you
it's not,
discriminating against thongs. Like, okay,
but
Thongs too, but I ain't wearing them all
it's
day.
not good for women's health, honestly. So I
yes,
really don't understand why they sell it. I do understand why, but the point is it's not good for women's health. It really isn't.
Mhm.
Just like Victoria's Secrets is not good. You know, the Bath and Body Works is not good for women's
right.
health, that kind of thing. Okay. But yeah, that is the end of this scenario. Okay, I'm gonna stop sharing my screen and I'm gonna stop recording.